surgery has now attained the status of a refractive procedure. Our patients have become more demanding, and therefore it is necessary for us to target the bull's eye in our IL power calculations. Cornea plays an important role in this process. It determines the optical performance of the theoretical eye model. Different shapes of the cornea alters the aberrations and thereby the visual quality of the eye. It also contributes in predicting the post-operative effective lens position. A regular cornea is characterized by its keratometry value, which is usually calculated from the anterior curvatural radius of the central cornea. However, in an irregular cornea, the anterior to posterior corneal curvatural ratio is altered and there are higher levels of higher order aberrations. Therefore, the effective corneal power is difficult to predict. Our video highlights a step-by-step approach to tackle the difficulty in IL power calculation in irregular corneas. The first step is to identify an irregular cornea. The significance of the corneal irregularity on optical quality can also be assessed by a rigid gas permeable lens trial. It is also important to assess the mesopic pupil size because pupil determines the severity of optical scatter. Good topography is the key to IL power calculation in such cases. A minimum of 3 readings should be taken to ensure repeatability. The final and the most important step is to choose the correct IOL formula. To ease the understanding of IOL calculation part, we would be showing few case examples. Our first case is that of a 55-year-old woman who presented to us with cataract in her left eye and a history of myopic LASIK done 20 years back. To calculate IOL power in post-refractive surgery patients, we can use ASCRS online calculator, which is freely available. After filling in patient's details, this calculator allows us to fill in the pre-procedure records if they are available to us. However, it is not mandatory and only the currently available data is enough. The more the data from different machines, better is the outcome. After filling in the biometry data, the calculator will give you information for all the formulas available with the given data. In place of Atlas ring topographer values, the holiday equivalent K reading map can also be used. It gives equivalent K reading values in different zones starting from 1 mm to 7 mm. EKR65 mean can be used in this online calculator. After getting the results, the minimum or the average value should be used for best results in myopic LASIK. In cases of radial keratotomy, the target refraction should be kept as -1 or -2 depending on the cuts of the cornea. Other option to calculate the IOL power in post-refractive surgery cases is to use the total corneal power coupled with Holiday 2 formula. The brand of the IOL should be decided based on the spherical aberration of the cornea. Our second case is that of a decentered myopic ablation. In addition to increased internal aberrations due to cataract, there are significant corneal aberrations as well. Cataract surgery would reduce the internal aberrations, but the patient might still not be happy with the vision. In such cases, a preferred option would be to regularize the cornea with topo-guided corneal customization technique. Cataract surgery can then be done after keratometry stabilizes. A small study from our group found this technique to be effective in reducing the residual refractive errors. Our next case is that of a pellucid marginal degeneration. In this case, the histogram is like a broad plateau, but if you see the axis in each zone, it is the same everywhere and even the astigmatism value is in the range of 5 to 6 diopters. This case can be considered for toric IOL implantation using company-based calculators and keratometry reading from the 4 mm zone. Cases after corneal transplant present with high amount of astigmatism. Such cases can be treated with customization of toric IOL and they give good visual outcome. Irregular corneas can also be considered for multifocal lenses provided the higher order aberrations in these cases are lesser than 0.5 micron. To conclude, we would highlight that it is important to understand the cornea and its role in IOL power calculation to avoid error in irregular corneas.
Thank you, Luci. Okay, I think your second case which you described, you first regularized the cornea by surface ablation?
Yes, sir. Topo-guided ablation.
Topo-guided ablation,
Yes,
and then you did the cataract surgery.
Yes, sir.
My question is, would it be appropriate first to go ahead with the cataract, maybe even if you are a little bit wrong here, at least the second one will give you a chance, either LASIK or surface ablation, whatever it may be, to correct all spherical as well as symmetrical aberrations.
So this is an ongoing debate. There are two schools of thought. Certain people believe that treating the cornea first and then going ahead with cataract surgery makes it more stable because you will have a stable cornea. And there is another group of thought.
How long did you wait after the surface ablation?
We waited at least 3 months. Our idea of stability was to wait for 3 consecutive visits where more keratometry didn't differ more than 0.2 diopters. So that debate, anyways, both ways are correct. This is not something that we can say.
Definitely it is a better idea to correct later on so that you can correct whatever residual error are there.
So, but in that the other problem is when we treat the cornea later, the keratometry values would change. So the IOL power that we have put is based on the earlier keratometry. If it alters a lot, especially in these decentered ablations.
Whatever is the residual error.
We are going to correct the refractive error only on the cornea. Total whatever you are having, whether it is spherical or cylinder.
So in certain case examples that we saw, because these are decentered ablations where you would try to center it. So the keratometry, effective keratometry would also be changing. When we do the routine cases, we are treating just the refractive error. But when we are talking about irregular corneas, especially in decentered ablation, the keratometry per se gets altered by that as well. So
maybe some effect on the aberration probably that you can. Okay.
Okay, thank you. Thank you very much. Now we invite